Good evening, folks, and welcome to tonight's Men's Health webinar. Tonight, we have the pleasure of hearing from Dr. Alex Tatem. Dr. Tatem is a urologist, a men's health specialist. He has unique and extensive training just in the men's health area. He's a wonderful presenter, wonderful doctor, and an even better human being. He's going to talk to us about the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. I encourage you to ask questions anytime during the presentation. To do so, simply tap the screen of your mobile device, move your mouse on your laptop or desktop. A toolbar will pop up. Click on the chat button. Submit your question just by typing it in there and hitting submit. Without further delay, I'd like to introduce Dr. Alex Tatem.
Thanks, Mike. I really appreciate that overly generous introduction. And I just want to address everybody attending tonight. I really appreciate you guys taking the time to learn about these, incredibly important men's health issues that I think too often get brushed aside or get kind of minimized. But at least for me in my career, I've dedicated my practice to the quality of life concerns that are just so critical for guys, the issues of intimacy and continence. And tonight we're going to discuss those at length. And I want to let you know that tonight is about you. Tonight is about you, the attendees, making sure that you get your questions answered in a way that is comfortable and convenient for you guys, where you get to maintain the comfort of your own home. And so I would encourage you, as you think of questions, go ahead and type them in. We'll address them at the end, but don't wait. I know I can't remember anything unless I write it down, but as these things start to come up in your mind, write it down. This is meant to be a conversation and really a dialogue for you guys. So without further ado, I will try to get my computer to work and we will move on with tonight's presentation. So let's see here. We're going to do this. One moment. And I'm going to ask for confirmation. Mike, you should be able to see.
Yep, it's up. Looks good.
Awesome. So again, welcome everybody to tonight's webinar. So like Mike mentioned, my name is Dr. Alex Tatem, and I want to give you guys a little bit of background. So I am a fellowship trained board certified urologist. What does that mean? It means that after medical school, I dedicated my career to urology, but not just general urology. I actually did additional training beyond the 5 years that all urologists do to specialize in what we call male sexual and reproductive medicine. So that is what has allowed me to really dedicate and tailor my practice to just these quality of life issues. So I often joke with my patients that I'm probably the worst guy to take care of your prostate whenever it comes to prostate removal for prostate cancer or the issues of like kidney stones or bladder cancer. That's just not what I do. But I've been able to completely dedicate my career to the issues we're going to talk about tonight of both restore incontinence, which is the ability to hold your urine after radical prostatectomy, and to be able to restore sexual function for men, and also male fertility. And I've left up the picture of my good friend and colleague, Kristen Gumpf. For those of you that have been able to meet Kristen, she is my PA, my physician's assistant, and she is like my right hand. My practice does not run without her. And if any of you ever receive care from me at any point in time, you will most likely meet her. She couldn't be with us tonight, but I wanted you to hear her name and see her face, so that way she's familiar with you if you ever have the opportunity to join our office. So, all right, let's start off talking about erectile dysfunction and treatment options. And I think this is actually a very common question I get, but what is erectile dysfunction? How do you categorize that? Because I think a lot of people are, concerned, is ED, this complete inability to have, an erection? Doc, I can't get an erection most of the time, but once in a blue moon, it kind of sort of works. So do I have ED or not? And I try to make it really simple for patients. When your penis doesn't work the way that you need it to for sexual intimacy, that's erectile dysfunction. And, maybe it's once or twice whenever you're younger, but as we get older and as our bodies start to experience more wear and tear, when, our, sexual organ, when our penis fails to rise to the occasion, so to speak, on any sort of regular basis, that's ED, and it deserves to be treated and it deserves to be discussed. And I think what really surprises most of my patients is how common this is. This is going to affect the vast majority of men. And really, the data would show up to 50% of men over the age of 40 have some degree of erectile dysfunction. And I'm very transparent with my patients. I honestly hope one day that I develop erectile dysfunction, because if I don't, it means I got hit by a bus first. And I say that to illustrate that this is a natural consequence of aging that will happen to all of us eventually. So there should be no shame when talking about it, because we're all going to deal with it at some point in life if we live long enough. But the good news is that we have amazing solutions for it. So you don't have to be stuck dealing with ED for the rest of your life. So how do erections actually work? And this is something that I think is news to a lot of patients whenever I talk to them. No one ever really talks about, what is the anatomy of the penis and how is it supposed to work? And you can't understand how we fix things unless you understand how they were supposed to work to begin with. It's kind of like whenever I take my car to the mechanic, if you don't understand how brakes work and he talks about changing your brake pads, you just kind of smile and nod, unless you actually know that brake pads go on rotors, et cetera, et cetera. So the way I explain it to patients is that your erections are actually incredibly simple. They're just two inflatable tubes that start in the pelvis and go out the shaft of the penis. And what's supposed to happen is when a man is sexually stimulated, when he's aroused, there is a rush of blood into those cylinders. Those blood vessels dilate, and that means they get larger and allow more blood into these inflatable cylinders, which then fills them with blood. That allows them to become firm and rigid and to be used for penetrative intercourse and sexual activity. Then after climax, the pop-off valve opens back up and everything drains out. So it's basic hydraulics. If you can understand basic hydraulics, congratulations, you now understand erections probably better than most physicians. And so that is how things are supposed to work. But as we're going to talk about tonight, that system can break through a number of different ways. Now, when we talk about erectile dysfunction, we talk about its effect on, the ability to perform sexually. But something that I see every single day in my clinic is the far-reaching side effects of erectile dysfunction that go far outside the bedroom. Because the truth is that intimacy can affect every part of our lives. And as men, it affects our self-confidence, our self-image. It affects our relationships, whether it's in the bedroom or it's just having that comfort level with your spouse to flirt in the kitchen and to cuddle on the couch and to know that if anything would lead to something else, you could, perform. I have so many men come to me who have drifted away in their relationships as the result of their erectile dysfunction because they have that fear of that intimacy and what happens, doc, if I'm just not able to perform and I'm embarrassed yet again. And unfortunately, this is a snowball effect that can lead to depression, it can lead to anxiety, it can lead to isolation, and men just aren't present whenever they're with their friends and loved ones. So yes, I treat erectile dysfunction, but whenever we talk about it, we're really talking about treating much more than that. We're talking about the social and the mental health issues that come along with ED. So I think it's important to talk about ED because it affects much more than just sexual function. All right. So, what are some of the contributing factors to erectile dysfunction? Again, if anybody lives long enough, we're all going to get erectile dysfunction as men eventually. But the top physical causes are, vascular disease, diabetes, which diabetes causes vascular disease, so it kind of dovetails into that pretty nicely. And then lastly, medication. And what patients will often tell me is, doc, I was doing okay, but I have this high blood pressure, and my primary care doctor started me on this blood pressure medication, and now I have erectile dysfunction. So really, the problem is this medication. That's the issue. And how I try to educate my patients is that's not actually the case. High blood pressure is one of the leading causes of both heart attack, stroke, and is directly correlated with early onset Alzheimer's and dementia. And so when you have high blood pressure, your body's vascular system, it's broken. It has been busted. And in order to keep you safe, we have to use medication to kind of, to drop that pressure, to keep it within a safe range. And a lot of times the side effect is erectile dysfunction. And so what I try to explain to patients is it's kind of like taking a car that isn't rated to go, let's say 60, 70 miles, on the highway. Let's imagine I'm driving, my grandfather's, 20 some odd year old F-150. You take that thing, above 70 miles an hour and it just starts to rattle and creak. And it's not something that you necessarily want to take on a long road trip. And, when you start to all of a sudden drive it slower, things calm down. And, you could say, the problem is we're driving too slow. But like, no, like, it's not meant to go that fast. And whenever you have a circulatory system that is under the stress of high blood pressure, it's already damaged. Blood pressure needs to be brought down to keep you safe, but don't blame the pill. We need to treat the erectile dysfunction itself and not focus on the medication that men may associate with it. Now, moving on, the second most common cause of erectile dysfunction, or the second most contributing factor, is diabetes. Unfortunately, if you receive a diagnosis of diabetes, it's not a question of if you're going to develop erectile dysfunction, it's when. 1 out of 2 guys with diabetes have some sort of erectile dysfunction or sexual dysfunction related to that diabetes. And the challenge is that with men who are diabetic, not only are they going to develop erectile dysfunction sooner, they're going to develop more significant erectile dysfunction, more profound ED that requires more advanced interventions sooner as well. So if you're a man with diabetes and you begin to experience erectile dysfunction, I encourage you to seek care even sooner than you might. A lot of guys like to kick this can down the road as long as possible. And really, that's not going to be in your best interest, because we know that this pre-existing diagnosis of diabetes is going to kind of further your progression faster than we want. So jumping on top of it ahead of time is going to be the best thing you could possibly do for yourself. Now, one of the things I try to point out to patients who come to me and they're in excellent health, they actually don't have any diabetes, they don't have any known vascular disease, but they have profound erectile dysfunction, is that a common cause of that is vascular disease. And it's just a matter of scale. If you look at the size of the arteries that are in the heart, the head versus the penis, the penile blood flow, or the penile artery, is about 1/3 the size of the coronaries or the cerebral blood vessels. That's a really profound difference, especially if you start doing the math that's involved in how much fluid can go through a small tube versus a large tube. Exponentially more fluid can go through a tube twice the size, not just twice as much. It's, as much as 3 to 4 to 5 times as much. So as we decrease the diameter of a blood vessel, that means that it is much more delicate and much more susceptible to damage. And that's why even men that don't have some of the risk factors we discussed earlier can really have profound ED long before they have anything else. And it's just a matter of scale. And we've got this really good chart here illustrating that. Another big part of my practice is prostate cancer survivorship, and erectile dysfunction comes hand in hand with prostate removal. And there are a lot of complex reasons for that, but one of the biggest contributing factors are the nerves that supply erections. So if you think about that system that pumps blood into the penis as being just that, a pump, the electrical wiring that tells that pump to turn on and off is densely attached to the prostate. And now my partners who are dedicated prostate cancer surgeons are extremely adept at sparing those nerves and brushing them to the side, but damage can still happen. And a lot of times the prostate is necessary for erections in some men versus others because of the way the blood flow in the pelvis simply works. And that's not something that can be predicted ahead of time. So it's important to know about the risk of erectile dysfunction going into surgery. It shouldn't scare you away from it, but it should prompt you to seek care as you start to go through your radical prostatectomy. So that way you can get on top of this and treat it sooner. And that's one of the reasons why we have a really well-established prostate cancer survivorship program at our practice that I'm extremely proud of. So we know that erectile dysfunction and sexual dysfunction is really more of an expectation after prostate cancer treatment than maybe what some people might believe. The truth is that it doesn't matter which you choose, whether it's radiation or it's surgery, there's going to be some sort of fallout. And some patients, that scares them away from it. And what I try to tell them is that, prostate, I can fix anybody's erections. I can fix anybody's sexual dysfunction. You know what I can't fix is I can't fix prostate cancer that's gotten outside the prostate. Nobody can. And that's associated with absolutely devastating lifelong treatment with androgen deprivation. That means that you have to take all your testosterone away from your body, puts you in a state where you put on weight and fat and you're tired, you lose your libido, then your sexual dysfunction is guaranteed at that point. So, really the best thing that you can do if you're diagnosed with prostate cancer is to pursue treatment at an experienced center, but preferably one like ours that has a survivorship component. So as you go through that treatment, you can prioritize those quality of life issues so we can preserve your sexual function or restore it if need be. And so I think that really our survivorship program is one of the things I'm most proud of, because being able to guide men through that cancer journey and maintain that confidence that they're going to get a great outcome no matter what, it's been an absolute joy. So now we want to get on to another potential cause of erectile dysfunction, which is also very common in our practice, which is Peyronie's disease. So Peyronie's disease is a scarring disorder of the penis. And it's one that is surprisingly more common than you might think. It's been estimated to affect anywhere from 7 to 8 to up to maybe 12 to 15% of men starting around in their 50s. There are younger men who can get it and older, but that's where you start to see it become more common. And like I mentioned earlier, your erections are just two inflatable tubes, but the casing that makes up those tubes can be susceptible to scarring as we get older. And scars, as you might experience from prior injuries, are very tough. They are not very flexible. So when you get a scar in an inflatable tube, well, when you fill that tube full of fluid and it stretches, everything stretches except for that scar. And that scar can cause pain. It can cause curvature to the penis. And in some men, it can cause significant erectile dysfunction as well. And that's all because we've now compromised the ability of the penis to hold blood. So this is an important thing to learn about and understand, because if you ever notice a lump, bump, or curve to your penis that wasn't there previously, that's something that we can treat and we can improve. And you want to get on top of it sooner than later, simply because it can lead to more profound sexual dysfunction issues like erectile dysfunction. So 1 second here. Okay. All right. So on to the next. Sorry about that, guys. So let's talk about treatment options for our erectile dysfunction. So this is actually, you might have seen this before. This is a slide that I have actually as a poster in my office. And I think it does a good job of kind of summarizing all the different treatments for ED. And I want to go through them kind of one at a time. So looking here, we're starting with oral medications. So I'm sure everybody on this call has heard of Viagra, Cialis, Levitra is another one. These are medications that can actually be taken by mouth prior to sex. And what they do is they cause the body to dilate those blood vessels more than they ever would on their own. And so by putting your thumb on the scale of the chemical reaction that can cause an erection, you can actually treat mild to moderate ED with oral medication. The challenge is that these medications don't necessarily work for everybody. And so in my practice, I rarely see men who haven't tried these because they're so ubiquitous. You can get them by mail now. I have so many different primary care doctors that prescribe these very readily and are very good at prescribing it. I see the men that have hinged their hopes and dreams on these medications just to be disappointed. And I think that's something that has been encountered many times, especially for men that have only seen, let's say, either primary care doctor who doesn't know about maybe the more advanced treatment options. And just for statistics' sake, you should know that up to 15 to 50% of men will not respond to these medications at their first try. And everyone's going to fail them eventually. And that's just because erectile dysfunction is one of these progressive disorders that only gets worse as time goes on. And it is important to know that if you are taking a nitrate medication, which is a medication for the heart to improve blood flow, you cannot take these medications. I saw a man the other day, actually it was earlier today, who could not take these medications because he needs nitrate medications to keep his heart healthy. And so we needed to move on to a better treatment option for him. So let's talk about some of those other treatment options. So this is a treatment option that a lot of men are familiar with, called a vacuum erection device. And this is simply a suction tube that can create a seal with the skin around the penis. And as air is evacuated from the cylinder that pulls blood into the penis by forcing it. And then men who desire to use it for sex can actually take a rubber band, roll it down from the cylinder to the base of the penis, and trap blood inside. And this can allow a lot of men to achieve an erection manually. The challenge is it doesn't look or feel like a real erection because all of a sudden the penis is hinged where it meets the body, so it can be kind of floppy. It's cold because it's not getting fresh blood, and you can get some decreased sensation as time goes on. Plus, you can't wear it for that long because you're basically putting a tourniquet around the penis, and that is going to cause problems with circulation. So, I think the vacuum erection device serves a pretty good role in sexual medicine when it comes to recovering from injuries to the penis, when it comes to recovering from prostate cancer surgery. It's very good at rehabilitating the penis, pulling blood in there and softening the penis in anticipation of a better option to restore sexual function. But as a long-term solution for ED that you have to pull out of the closet every single time you want to be intimate, the vacuum erection device really leaves most men lacking. And so I think it's important to know about and to understand, but you also have to understand some of the side effects and some of the drawbacks from this modality in particular. Now, this is kind of put in here for posterity because it's not actually used anymore in modern practice, but this is the urethral suppository. And this is just a pill that goes into the tip of the penis. I know, sounds horrifying, but yes, this is indeed a treatment for erectile dysfunction that existed for many years. Unfortunately, it's hard to get these days. It's expensive, and the number one effect of it is not an erection. It is urethral burning. So it is not something that is used today with any regularity. I treat thousands of men every single year, and I've not found a single guy that wants to try this or has had good results with it. So the most men who come to see me really end up trying to decide between two key options, and those are the ones we're going to cover next. The first of these is something called intracavernosal injections. And I want you to think of injections this way. Imagine we could take that same sort of medicine that is in a pill and then dissolve it into a little solution, a little bottle that can be done at a very high concentration. Then you can actually draw that medication up with a very small needle and then inject it into the side of the penis. Now, because this is administered directly where you want it and not as a pill, you can get much higher concentrations right where you need it. And a lot of men who didn't respond to oral medication respond to these injections. And so it's something that's definitely worth learning about and worth considering. The challenge with the injections really comes down to just spontaneity and convenience. Because these medications must be kept cold, every time you want to use an injection, you have to go down to the fridge, pull out all of your supplies, administer the shot, and then run upstairs and hope that your partner has not fallen asleep. And I will tell you, this can be a very harrowing endeavor indeed if you have a multiple story house and you live in the cold Indiana winter. I can't imagine trying to drop my pants in the middle of my kitchen in the winter. But I do have a lot of patients who use injections and manage to find a way to make them work for them. But that success rate at 1 year is only about 1 in 5. So that means if I start 5 guys on injections in 1 day in clinic, only 1 will still be using injections about 1 year later. So most men who come to see me are interested in a better long-term solution. Maybe it's a stereotype, but generally speaking, as guys, we just want to fix things. We just want to address the problem head on, be done with it, and then move on with our lives. And that's what guys come to see me for, looking when it comes to a solution for their sexual function. And we have that. I explain to patients like this. Move on to our next slide. So just take a break from looking at this slide for a second and just pay attention to what I'm trying to describe to you guys. If we go back to the penis itself, how does it work? Well, it's 2 inflatable tubes, right? These are inflatable tubes that start in the pelvis and go out the shaft of the penis. Well, what if that's what we need to fix? We just need to focus on those inflatable tubes. What if we treated them like every other part of the body? So let's give you another example. Let's say that we are talking about arthritis in the knee. So arthritis is a really good analogous disease process to erectile dysfunction because we're all going to get it eventually, and it only gets worse as time goes on. So if you ever have bone-on-bone arthritis and you can't walk down the hallway because of that excruciating pain in your knee, that's something that pills don't fix, shots don't fix. You got to go see an orthopedist and you got to get a new knee. That's just how it works. You need to replace the broken hinge with a new one. And what we do when we're thinking about a permanent solution for erectile dysfunction is just translate that same way of thinking onto the erection. So we say, hey, listen, if these are just inflatable tubes, and that's all they are, what if we could make a small opening in the skin, only about as big as maybe 2 to 3 centimeters, and then slide our own inflatable tubes inside the body's natural ones. It's totally invisible. Nobody could ever see that you've had anything done. But when you want to get an erection, instead of relying on pills that don't work or shots that are uncomfortable or inconvenient, you can reach down and underneath the skin of the scrotum, there's a small pump that's totally hidden and private. No one can see it, but you can feel it. And when you squeeze that pump, it fills those cylinders with saline the exact same way your body used to fill with blood flow. And that can allow men to achieve a firm, reliable erection on demand, last as long as they want, whenever they want. And that is the penile implant. And I think understanding that your body already has inflatable cylinders naturally, that's what's broken. And that's what we need to reinforce, really is what makes this start to make sense. But what I like to do is show a lot of patients a video. This is on our website as well, that demonstrates this in action. And so this is a really good animation that shows what implant inflation and deflation looks like. So a lot of guys ask, what does the implant look like? And I tell them it just looks like you, because as you can see in this illustration, it's all internal. No one can tell you've had one looking at you. But as you squeeze that pump, you can see how saline fluid moves from a little reservoir that sits in a fat pad in front of the bladder into the cylinders. The penis is firm, rigid. It looks natural. It feels natural because it is your penis. And then as the button is pressed, the erection goes back down and guys can go about the rest of their day. And so I think it's important to remember that when it comes to sexual function, a guy's sexual experience in the bedroom really breaks down to 4 things. There is erection, which is what we're talking about tonight, sensation, orgasm. Orgasm is that good feeling in your brain, and then ejaculation, which is the expulsion of fluid. And what's nice about the penile implant is that it fixes erection without affecting those other variables. So it doesn't affect sensation, it doesn't affect orgasm, it doesn't affect ejaculation. So you can maintain and your sex life, have an awesome sex life, a better one than you've ever had before, and not have to worry about having any changes. Besides, now you can achieve that erection and maintain it for as long as you need to. And that's what I love about the implant, is that it's designed to be a permanent solution for erectile dysfunction, rather than something that you have to keep up with when it comes to visiting the doctor with multiple visits thereafter and having to manage with multiple trips to the pharmacy and trying to hide a brown bag and feeling embarrassed. You can be confident and independent. And after my patients are fixed, they've received their implant and they're working it, they get the luxury of not having to come back to the doctor. And I tell them, if you ever have any issues, just come find me. I've got a 6-month-old at home. I'm not retiring anytime soon. So something that I have to talk about is the issue of insurance coverage. What's nice about the implant is that it is covered by Medicare, just like any other procedure. And so if you're a man with Medicare, that covers 80%. If you have a secondary, that picks up the remaining 20%. And when it comes to commercial payers like Anthem or Aetna or Cigna, whoever the case may be, we just check your individual plan and we see if you're covered long before we make any decisions. So something that is important to know is that the implant is a procedure. We do it, in an operating room. That being said, getting your prostate out is a big surgery. Getting, kidney stones removed, that's a big surgery. A penile implant has been designed to not be a big surgery. I joke with my patients, I don't like big surgeries. That sounds, it doesn't sound pleasant. In our hands, this is a 30-minute outpatient procedure where you go home the same day. Men do not need to stay in the hospital overnight for this. In fact, I haven't had to give a single script for narcotic pain medication in 4 years at this point. Men just don't need it. And I do hundreds of implants every single year. Our goal is to make this as easy and as accessible as possible. And I think that that's what's really great about having a dedicated center, is because we do so many of these, we're able to replicate it and consistently get great outcomes for guys. So again, ED is a common problem. Everyone's going to experience it at some point in their life if they're a man, and there are a variety of treatment options, but you deserve to have this fixed. If you are alive and you are healthy enough to undergo a quick 20-30 minute procedure, then you deserve to have your sexual function restored. Life is too short for anything else. So with that, I want to move on to the second part of our talk tonight, which is understanding male stress urinary incontinence. Now, male stress urinary incontinence, that is a mouthful. And I like to simplify it to something that's a little bit better to understand, which is just bladder leakage. Specifically, it is leakage from the bladder in men who have had their prostates removed for prostate cancer. And in some select men who have also had their bladders removed and had something created called a neobladder. This is a very specific type of urinary leakage that's different from urine leakage for men that still have a prostate in place, that is exacerbated by coughing, lifting heavy things, sneezing, and leakage of urine in those settings. So it's called stress because when you stress your body, stress your abdomen, you involuntarily, so against your will leak a little bit of urine. And this is a pretty devastating thing to live with as a guy, because these are commonly cancer survivors, men that have, stared death in the face and beat it, but now they're left with this burden of dealing with pads or depends, and they really lose that confidence to kind of live the life that they've regained after their cancer treatment. And it's estimated that anywhere between 9 to 16% of men will have some degree of leakage after having their prostate removed 1 year later. I will tell you, in my practice, seeing hundreds of men every single year, I actually think it's a little higher than that. So let's keep going here. So let's talk about the urinary process. So your urine is actually just blood, and it's blood that's been filtered by the kidneys out of the toxins that are no longer needed. So your kidneys are this big set of filters that go ahead and process the blood, screen it out, and then afterwards it trickles down into the bladder where it's stored. And then, once your bladder is full, you have the urge to urinate and you run to the bathroom. Now, in men, a gland that sits right in front of the bladder and is really important for maintaining that ability to hold urine is the prostate. And so it's important to realize that these are all part of the same pipeline. They're all part of the same plumbing. The prostate doesn't sit off to the side of the bladder. It is intrinsically associated with both the bladder and the sphincter muscle, which is that muscle that you can squeeze to try and start and stop your urine stream whenever you're going to the bathroom. So when men have their prostates removed, that is why that network, that plumbing can be disrupted and men can really struggle with urinary leakage. Now, there are a handful of other conditions that can cause this, like issues like injury to the spinal cord, injury to the pelvis, radiation, and potentially enlarged prostate surgery. Those are not as common, but I absolutely see them in my practice. It requires a little bit more nuance when it comes to sorting out what type of leakage we're dealing with. But stress incontinence, which is leakage with straining, is absolutely possible with any of these conditions, and it deserves to be treated. So just as erectile dysfunction can affect quality of life, urinary incontinence can do the exact same thing. And for a lot of men who struggle with both leakage and with stress urinary incontinence, with leakage and erectile dysfunction, the erectile dysfunction will affect their ability to interact with their closest loved ones. The leakage affects their ability to interact with the world, because when you're leaking urine as a man, when you have that smell that you're always worried about, is someone going to see the stain on my shorts? Is someone going to, smell urine? Can I even sit next to anybody in church? All of a sudden, you don't just withdraw from your relationships, you withdraw from life. So this is a really devastating thing for guys to deal with. And it can be a challenge because a lot of guys can go to their prostate cancer surgeon or other doctor, and they're like, well, I'm only leaking 1 or 2 pads a day. Maybe I should just be grateful I'm even here. And I mean, by all means, thank the good Lord that you've, survived cancer and you're on the other side. But just because you're leaking only 1 or 2 pads a day, if it's a big deal to you, it should be a big deal to us as your physicians. And that's something that deserves treatment. So what happens during radical prostatectomy is prostate is removed, and you saw a slide like this earlier where the nerves are brushed to the side, but you have to sew the bladder and the urethra back together. And that process of prostate removal and then sewing of the bladder to the urethra can injure the sphincter. And as a result of that, you can have increased urinary leakage. And also, these nerves that are associated with erectile function are actually pretty closely associated with continence too. So that's why you can have men who struggle with both erectile dysfunction and urinary leakage after prostate removal. So it is important to know that everybody who has their prostate removed, you're going to leak. And I tell patients who come to see me as part of our prostate cancer survivorship program, just plan on bringing some Depends to the visit where your catheter is removed after surgery. Regardless of how good your surgeon is, that is such a radical change for your body to have your prostate removed. You're going to leak urine afterwards. Just give yourself some peace of mind, bring extra pads, and that is going to give you that security when you first go home. Now, what's supposed to happen is that continence is supposed to improve pretty quickly. For men that see us in our survivorship program, we have them start to do Kegels before surgery and immediately afterwards. We'll even do some more advanced treatment like pelvic floor physical therapy. But when you get 3, 4, 6 months out, you should be getting better by then. In fact, at 6 months, 94% of guys that are going to get dry will have already gotten dry at 6 months. So if you're still leaking at that point, it's time to start talking about doing something about it, because it's going to be highly unlikely that you're going to be able to regain that continence without some sort of additional help. So what are kind of short-term treatment options immediately following prostate removal? Some guys try to reduce their oral intake of fluid. I don't recommend that because honestly, we're dehydrated as a society in general. Planned restroom breaks, though, that can be really helpful trying to structure out your day so your bladder doesn't get too full and you don't exert too much pressure on your sphincter. Pelvic floor physical therapy, I think, is amazing, as are Kegels. Biofeedback is a special type of exercise that is done in pelvic floor physical therapy. These are extremely beneficial ways to aid recovery as you start to go through those first few months. And then at the end, you kind of have coping, which is just getting through the day. Those are your diapers, your pads, catheters that go around the penis. Condom catheters is what they're called, and penile clamps. We're actually kind of pinching the penis to keep the urine flow at bay. Coping mechanisms are not a long-term solution. Nobody wants to be in a situation where they're trying to calculate how many diapers and how many pads they should bring with them on their golfing trip with their buddies. And I honestly have patients that are stuck in that conundrum where they're looking at the elevation change because their friends insist on walking the back 9, and they don't know whether or not they can stuff enough diapers in their golf bag so they can change their pad in the woods and try to hide their urinary leakage from their closest friends. If you start to do that, the mental load becomes unbearable after as time goes on. And ultimately, it turns out to be pretty freaking expensive too. This is an old slide, and the cost of 5 pads per day over 5 years, it's a lot more than $7,000. You can thank inflation for that one. So what are actual treatment options? And we've got 2 of them, and they're both beautiful and for different men. So the first one is something called the male sling. And the male sling is an outpatient, very quick procedure that is designed to lift and elevate the urethra to add passive resistance to the system. So your urinary system doesn't change at all as far as you're concerned, but by elevating and changing the position of the urethra, we can increase the resistance so your body doesn't have to lift as much weight to hold on to your urine. The analogy I'll give to patients is, imagine you're at a gym and you're lifting a bunch of weight on a bench, and all of a sudden you just take off some plates on the side. This is a great way for most men with mild leakage to control their bladder. Efficacy is about 84%. So that means in well-selected guys, more than 8 out of 10 of those men will either get to being completely dry, or they will be about maybe less than 1 safety pad a day. But what's nice is that they don't have to think about anything. It's a one and done thing. It's the closest thing I have to a magic trick, because a man goes to sleep, he wakes up in the recovery room, and he's already dry. At least when it works its best, that is what you get to experience. And that's really cool to see. Now, for men that have more significant leakage, we have a device called the artificial urinary sphincter. It's a little bit more delicate and a little bit more sophisticated. And we'll talk about that here as we get to a slide where you can see an image of it. And I think it'll make more sense. So this is a picture of the male sling. You can see how it's a little piece of mesh that is designed to lift and elevate the urethra being that tube right there. Imagine you're looking at a pelvis. So I think as if a guy was sitting in a chair with his legs up, almost like a woman giving birth. That's the angle we're looking at here. And this is a quick procedure. It only takes about 30 to 40 minutes in a surgery center, and you don't have to worry about it as a patient. Once it's in, it starts doing its job. Now, let's go and talk about the artificial urinary sphincter. The artificial urinary sphincter, also known as the AUS, is designed for men that have more significant leakage than our sling patients. These are guys that are leaking 5, 6, 7 pads a day, or men that have been exposed to things like radiation, men who leak urine constantly, even whenever they're laying flat. That's what the AUS is for. And the AUS is, imagine a blood pressure cuff that can stop urinary flow. So a blood pressure cuff wraps around your arm and squeezes it. This is much like that, except imagine a blood pressure cuff that's so small it could fit around the tip of your pinky finger. That's what this urinary cuff is. And as you can see in this image, it's wrapped around the urinary tube, the urethra, and at baseline pinches it off so urine cannot leave the bladder. Then when men feel like they need to urinate, they can reach down and squeeze that small pump, which releases that sphincter, opens it up so that guys can start urinating freely. And I think this is really beneficial to watch an illustration of this, because it's cool, but it can be hard to kind of picture in your mind's eye as a patient, especially hearing it for the first time over a computer screen. So here we can see that everything is internal, much like the implant. Nothing can be seen from outside. Urine is allowed to store in the bladder with that cuff inflated, but when a man squeezes it, it actually deflates the cuff. That means the cuff opens wide open, and then the bladder squeezes and men can urinate freely. And then the device automatically turns back on without the patient having to do anything else, and it stops the urine flow again. And I really think it's a beautiful option for guys that have more significant leakage. So I encourage you that if you're a man struggling with incontinence or bladder leakage, take control of it. You don't have to keep living in pads and diapers and making your life revolve around your urinary leakage. Come seek a consultation with myself or another expert, because there is a better option out there. So as we mentioned, there's risk with every procedure. That includes the male sling and the artificial sphincter. I talk about this in detail with men whenever I see them in clinic, but the benefit of these procedures is that they are minimally invasive, they are quick, they are outpatient, and success rates are very high. So insurance coverage is actually really great for both of these procedures. We always check it before we ever commit a man to surgery to try and avoid any unfortunate surprises. And we've had really, really great results. So in summary, stress urinary incontinence, also known as bladder leakage, is a known side effect of prostate cancer treatment, along with some other medical conditions. And yes, you can cope with it, but you don't have to live with it. Coping is not living. And I encourage you to seek treatment and find your long-term solution. So thank you very much for your time. Thank you for watching. We're going to open up the forum for your questions. And so please don't be shy, type away, and we look forward to getting you guys some answers.
Dr. Tatum, I want to start with some pre-submitted questions that we had, if that's all right.
Sure.
So gentleman asked, understand every patient's unique, but I'll be 2 years out from an open radical prostatectomy soon. Tried shots, both trimix, bimix, have not worked, but erections have improved to about 50 to 60% of what they were. What is the overall likelihood that a natural erection will return soon or at any point?
Yeah. So I want to highlight something there, which is trying to quantify the erection quality, of saying it's 50% of what it was, 60% of what it was. Erectile dysfunction is nuanced. It's not like a light bulb where it's on or off. We all know that our erections as guys in our 50s, even if it's still satisfying, suitable for intercourse, it was not our erection whenever we were 17 or 20. So what I try to tell guys is it's still, although it's nuanced, it can be complex, it's also pretty simple. Is your erection good enough for sex? Is it spontaneous enough? Can you get an erection on command? Can you maintain it as long as you need to? Does it make you happy? Does it make your partner happy? And if the answer is no, it's not good enough, well, there you go. You've got your answer. It deserves to be treated. And for men that have had radical prostatectomy, we want to see steady increase, usually starting around month 3, going into month 6 to month 9, going on from there. If I have a guy who hasn't had any improvement by month 6, we start getting some diagnostic studies to see what his long-term prognosis is going to be. Because every year that you go by having erectile dysfunction means that you're going to lose 1 or 2 inches off of your penis. And, I hate to say it, friend, 2 years out, if you have not returned to satisfactory erectile function, you will not on your own, and you deserve to seek treatment for that.
Thank you for that. There's another question related to someone who's had a prostatectomy. If they do get an implant, is there any risk or potential danger if they need radiation therapy down the road?
Absolutely not. We have that. Yeah, we encounter that situation all the time. We have really amazing, fancy radiation machines now, and we can work around the implant. It doesn't cause any issues whatsoever.
Now, on the prostate cancer front, post-prostatectomy, somebody asking about bladder leakage during sex. Is that something that's common? Is that something that can be treated?
Yeah, that is actually a really common situation that doesn't get a lot of airtime. So, a lot of patients will come in saying that they don't leak when they cough or sneeze, but the moment they start to become aroused, they will start to leak urine, and then it'll get particularly noticeable as they approach climax or reach climax. And so that condition has a name. It's called climacturia, and that is a condition that is actually really, really well treated with the male sling. Because, in a sense, climacturia, which is leakage with arousal, is kind of the mildest form of stress urinary incontinence. And so, just by adding a little bit more resistance to the system, the majority of men can get dry. So, they don't leak urine on their partner whenever they go to be intimate. And it's one of the many reasons that I try to screen all of my men who come to see me for erectile dysfunction after prostatectomy for leakage, because there is nothing that's more of a buzzkill than going through your implant procedure, finally getting back in the bedroom, and you start to use it, and all of a sudden you realize you're leaking urine on your partner. That's no fun. But the good news is we've got a great solution in the form of the male sling.
Thank you. There's a question about asking you to address the new experimental surgery that uses ultrasound.
Yeah. So, shockwave is what I believe that question is referring to. And it's making me start to feel old now. Shockwave is actually not that new anymore. It is new in the sense that it's the kind of the latest cool kid on the block when it comes to erectile dysfunction treatment. But we've actually had our our shockwave program in our office up and running for about 4 years now. And so Shockwave is not approved by the FDA for the treatment of erectile dysfunction. It is something that has been investigated in many, many papers and is used quite commonly in Europe and overseas. But the reason why you didn't see it in the presentation tonight is because it has not yet been approved for formal use in the United States. Now, Shockwave has been shown to be effective. So, as doctors, we can use these devices in that fashion, but it's technically considered off label. And the reason why that's important for you as a patient is that you have to understand that off label treatments are not covered by insurance. So, if you do pursue Shockwave treatment, it's something that is all cash out of pocket. In our practice, that's about $2,000 for a full course of treatment. And Shockwave, although it is very exciting, and I think a great option for mild erectile dysfunction, it has shown very poor outcomes for men that have ED that no longer responds to oral medication. And unfortunately, being the specialist, I often don't see guys until the pills have stopped working. So we have Shockwave in our practice. I love it. I think it's a great option for mild ED, but for most of the patients that come to see me, they've already progressed past the point for that to be effective. And I do want to just caution patients, not all Shockwave is created equal, far from it. Just like, all, sticks are sticks, but not, or all baseball bats are sticks, but not all sticks are baseball bats. Maybe that's a terrible, analogy, but there are other kinds of shockwave therapy called radio wave shockwave therapy, which is typically what you hear about on the radio from a lot of these men's clinics. Like, I don't want to name names, but I mean, there are a lot of them, and they, make you sign these agreements and membership programs and all that crap. And really, what they're offering is a glorified vibrator. So, to my knowledge, we have the only real shockwave machine in the state, and not because we're too fancy, but we're just the only ones willing to pay the full ticket price for it. So, yeah, buyer beware with shockwave therapy from a radio ad.
Amen to that. So we got a question about MRIs and implants, and if there's any risk of interference if you have an implant getting an MRI.
Totally safe. Yep. Tested up to a T3 MRI, which is the largest one that's available commercially, and no interactions.
Okay,
And same for airport security too. Guys are always worried about that. It will not trigger TSA. So I joke that if TSA pulls you aside for special screening, it's just because they like you.
We have a question about Peyronie's disease after prostate removal. Is it common or somehow linked to prostate cancer removal?
Extremely common. We think it's because the penis experiences decreased blood flow, and that can promote scarring in certain men. If men have erectile dysfunction and Peyronie's disease, they really do best with an implant. But if men have decent erections or erections that still respond to pills and Peyronie's disease, we like to opt for a even more minimally invasive approach with a medication called Xiaflex, which is actually Kristen's specialty. So in either case, if you experience a lump, bump, or curve, seek treatment because we can fix that.
Now, is it normal for testicles to retract, scrotum gets smaller, in parentheses, during erection? If so, why does this happen?
So the testicles are actually suspended by a muscle called the cremaster muscle. And depending on the man or the situation, if guys are exposed to the cold, they're aroused. Some guys, it can happen spontaneously without much warning. If they've got a hyperactive cremasteric response, you can have contraction of that muscle and it pulls things higher. And it does serve a physiologic purpose, because if you're, scared or spooked or about to experience some sort of trauma, you don't want your, boys hanging low where they're an easy target. At the same time, if you're exposed to any cold, your body wants to keep your testicles warm. And so that can prompt a retraction as well. But what's important to realize is that it's not a sign of anything like a cancer or a greater problem. It's just a normal reaction that can be more pronounced in some men compared to others.
Thank you. Now, going back to post-prostate cancer surgery. So someone says they're experiencing incontinence at night that kind of emerged. So if it were a full diaper in the evening, they were a thin pad during the day, but never have leakage. So why at night would they be leaking more?
That is interesting. So leakage after prostate cancer can have, there's a lot of nuance and complexity there. Generally, for most men, they leak more during the day. And that is because they have simple stress incontinence, which is leakage with coughing or sneezing. And because they're more active during the day, they leak more during the day. But when men are experiencing more leakage at night than during a day, that deserves a little bit more investigation. So in patients that come to me with that story, we'll actually get a couple of different studies. One of them is a cystoscopy, where we look into the bladder to make sure there's no scar tissue that could be altering how the bladder functions. And we'll even do something called urodynamics, which is like an EKG for the bladder. So seeing how well is the bladder empty? Is it possible that the bladder actually isn't emptying very well? And when you lay flat, that extra pressure from changing your body's positioning is causing you to leak more. Is your bladder hyperactive? Is it squeezing when you don't want it to? These are all kind of subtle questions that can be answered with some more investigations that we have at our disposal, but I don't insist on putting every guy through that, not if they don't need it.
Thank you. Now, when you're trying to determine for oral medications between all the options that are available, do you have a personal preference or specific considerations that you use to determine what's best for the patient?
Yeah, so I try to operate by the assumption that everybody just wants to feel normal, man. Like everyone wants to feel independent and strong. And, I have a lot of guys who come to see me saying, Doc, I hate taking medications because I hate feeling like I need a crutch. And so usually my first option for men with mild erectile dysfunction is just a low dose daily Cialis. This is a medication that costs, $17 for 90 days if you get it from Meyer with a good RX coupon. And just by taking it every day, you kind of remove that variability of, do I need to time this pill? Are we gonna have sex? Are we not? I joke with patients, I'm married, and I have no idea when I'm going to have sex. I just kind of take it as I can get it. And I think most guys feel the same way. You want that spontaneity. And so by having a daily pill that you kind of treat like a vitamin for your penis, that allows you to have that sort of, you're ready whenever the situation, presents itself. And for men that really need an extra boost, in addition to that, they can do a Viagra on an empty stomach 1 hour beforehand. So those are my two go-tos are Cialis, also known as tadalafil, and Viagra, also known as sildenafil.
So we have some implant recovery questions. So try to condense them into a series of questions here. So how long is recovery typically for a penile implant? And then can you share sort of the recovery process following surgery, including if there's a catheter involved?
Yeah, absolutely. So, no, there is no catheter involved for implants. I take care of too many prostate cancer survivors to traumatize my guys anymore. Most of them have some PTSD associated with having a catheter for a week and a half after their prostate cancer surgery. The most we ever do is, in some men, we'll do an in and out catheterization while they're asleep, but we don't leave anything in there. So, the surgery itself is about 30 minutes long, but I tell guys expect to kind of treat this like an all-day affair for you, because you got to get there, get dressed or undressed, so to speak, get your antibiotics, talk to the anesthesiologist, sign a bunch of paperwork, and then we actually get ready, get you in the room, get positioned, get you asleep, and then do the procedure. So when you wake up, there's a big fluffy dressing around the penis, but the head of the penis is still exposed. So that way you can still urinate normally. You don't have to worry about a catheter. And men will have a small drain, which is a little plastic tube, not coming out of the penis or the scrotum or anywhere down there, but just the lower part of the belly down in the right lower quadrant. And what that does is it actively pulls fluid away from where we did surgery, because anytime you do surgery in any area, you're going to get some sort of fluid that accumulates. And because we're near the scrotum can hold a fair bit of fluid, and that can cause swelling and discomfort. And we want to eliminate that or minimize it as much as possible. So when men wake up, they'll be a little bit sore. We use a lot of numbing medication during the surgery. So generally speaking, guys are pretty comfortable. They go home that same evening, sleep in their own bed. They babysit that drain, which means emptying it into a little container, writing down how much has come out. And they come back to our office about 2 to 3 days later. When you come back into the office, we examine the drain, make sure that we take down that dressing, examine you, make sure everything looks good. And for most men, we'll remove the drain at that time and then teach them how to massage that pump to the bottom of the scrotum. That can be uncomfortable for a lot of guys, but I tell them it's like, taking a dab of hot sauce. It's something that's, annoying, can make your eyes water for a little bit, but it's quick and over, very, very easily. So it's just something that you want to do regularly, a couple times a day as you're recovering for those first 3 weeks. So that way, 3 weeks later, your pump stays in the perfect position and we can go ahead and turn your device on. And at 3 weeks, the overwhelming majority of our patients are using their penis for sex and are independent from that day moving forward.
Thank you. So back to oral medications. This person's read that tadalafil is being used for benign prostatic hyperplasia or enlarged prostate. It can be taken as a drug, a maintenance drug for that reason. And I'm not sure what they mean by maintenance drug.
Yeah, so the guidelines for the American Urologic Association actually say that their first-line treatment for an enlarged prostate is either going to be an alpha blocker, so that's going to be medication like Flomax, or daily Cialis. So I think it's a really common choice for a lot of my partners who treat a lot of BPH, because in addition to maybe treating an enlarged prostate, it can also help with erections. I personally don't treat BPH, so I don't use it for that purpose, but it is nice when you can kind of get two birds with one stone.
Now, it's a question back to the implant. How many times do you have to pump it to have a full erection?
Depends how big your penis is. So when we're sizing these devices, we know that guys come in all shapes and sizes, right? No two men are exactly alike. So when we're in the operating room and taking these very precise measurements, stretching the tissue, trying to put in the largest implant as possible, those cylinder sizes, we've got an entire stack of them in the room, so we can get exactly what we need. but the pump is always the same size for every patient. So if you have a larger penis and larger cylinders, well, you got to move more fluid and that takes more pumps. But on average, most men are able to get to a full rigid erection at about 10 to 15 pumps. And it usually takes them less than a minute, minute and a half.
Thank you for that. So we got a question about venous leak and just what that is and how it affects erections.
So think of filling your inflatable tubes, filling your corpora. Think about filling those like filling a cup, like you're trying to pour water into it. If you're not able to fill the cup, you've got one of two things going on. The first is arterial insufficiency. That means you are not able to pour enough water in there. It's just a little trickle. And that's usually how erectile dysfunction starts. But when erectile dysfunction starts to get more severe, a bigger problem is, what if there's a hole cut into the bottom of the cup? Then it doesn't matter what you pour in there, it's just going to leak right out. That leaking of fluid from the system, that is venous leakage. That is the inability to trap blood effectively in the penis. And what you'll commonly hear from patients is, well, doc, I can get an erection. It may not be very hard, but gosh, the dog barks, I move and I lose it. Someone coughs, someone sneezes, we move too fast, then it's gone and I can't get it back. That's venous leakage. And venous leakage is particularly challenging to treat because it usually doesn't respond to oral medications. And men are left either using a vacuum device, they're left using the injections with a constriction band, also known as a cock ring, or they receive an implant and they have a more long-term solution.
Thank you. So question, if PD5 inhibitors can be used for fertility purposes, or if they increase sperm parameters?
No, they are two very separate mechanisms. When you're talking about fertility, you are trying to improve spermatogenesis, which is mostly a hormonal and endocrine signaling process. And with erections, you're mostly dealing with blood flow. Now, hormones can have a small effect on erections. If men have a critically low testosterone, that can affect erections, but overwhelming majority of times, erectile dysfunction, and I try to really drill this into patients because I think there's been a lot of unfortunate marketing out there trying to market testosterone as a panacea for everything, which is not the case. Erections are a blood flow issue. They're a plumbing problem, not a hormone problem.
You answered another question about ED as a side effect of hypogonadism and if treating it will always help. So knock that out.
Yep.
And then
worth treating. It's always worth treating the low testosterone, but low testosterone is rarely that silver bullet that kind of brings your penis back to life.
Now, for pills as medication, person asked, should they be taken daily or on an as-need basis for sex?
Why not both, man? Why choose? So that's why I recommend the daily Cialis with a breakthrough dose of Viagra, because that way you're getting that 1-2 punch and basically trying to max your dosage in multiple vectors.
So when somebody tries pills, fails, tries Bimex with bad results, and Trimex can only get and at best incomplete erection, what are their options to both help with 1, getting aroused, 2, feeling sensation, and 3, getting hard?
So this is an interesting thing to bring up. This is something that I don't think is taught in a lot of textbooks, but when men are using Trimix in particular, I've seen it happen with Super Bimix. I've seen it happen more commonly with Trimix, and absolutely with Quad Mix, is a decrease in sensation of the penis. You are trying to manipulate blood flow to an extreme extent whenever you're injecting that medication. I mean, this is potent stuff. It's like kerosene. And so when you're injected into the penis, it can cause scar tissue. And although it can improve blood flow to the corpora itself, it can actually constrict blood flow to certain areas of the penis. And that can cause problems with signaling because of the way that nerves work. So a lot of men will report decreased sensation with using injections. And so if a guy is experiencing those symptoms with injections, he is really going to get his best outcome from an implant. And the reason is that implants remove that pharmacology from the equation. Now you're no longer depending on trying to manipulate your electrolytes through a series of injections, because as you do that injection, you get a transfer of sodium and calcium that allows an unnatural increase in blood flow, but a restriction of nervous signaling. You're independent from that. You're free, and this is just based on the simple hydraulics of a device that is biologically inert. So you could talk about other things. You could talk about trying to use a vacuum device, but ultimately that's going to compromise sensation and appearance and how cold the penis is. If you want the most natural solution, it's going to be an implant.
Okay, and there's a reiteration person just want to make sure they understood one of the previous answers. So Cialis daily, but Viagra is just prior to sex. And then those can be used together.
Oh yeah, absolutely. I've got hundreds, if not over 1,000 men in my practice taking those medications. You can take those medications together. You just can't take them with a nitrate. So occasionally I'll get a pharmacist that, is having a heart attack saying they can't give it to a guy, like, oh my gosh, I'll kill him. That's wrong. It's very, very, very wrong. They're totally safe to take together.
Now, can a patient become desensitized to oral medication?
No. So this is not what you're talking about is an attenuating effect where all of a sudden the medicine just doesn't work anymore. The reason why medications don't work anymore is because the erectile dysfunction has gotten worse. So that is a progression of disease, not a resistance to medication. So it should prompt you to call your doctor, call our office, and to seek another option because, your erectile dysfunction, your blood flow to your penis has gotten worse, which means you're at a greater risk for losing length and girth as time goes on. I've had a lot of guys that, can't bring themselves to believe that. They'll want to go home and try a different brand of medication for 2 to 3 months, and all they lose is time and size off their penis.
So on that note, if somebody has had enough surgeries where their penis is retracted to being inside of them, they literally have to pull it out. Is there anything that can be done to help them with that?
Yeah, that's an interesting one, and it really depends on the patient and on their exam. So some guys are just really heavy retractors where there's a lot of tension in their penis. And that is something that can improve with regular use of a vacuum device to kind of relax the penis and kind of improve that elasticity. And honestly, an implant can be a good option for a lot of those guys because all of a sudden you turn into a shower rather than a grower. And that can be beneficial. I've had a number of patients who, although the implant does not make your penis larger, they're like, oh, my penis is bigger because it doesn't retract like it used to. But there are men where their retraction is really just obesity. It's fat above the penis and below the penis. It's kind of pushing up everything. Your penis is a fixed length, but if you get more obese, that fat can start to swallow the penis. And for men that have a lot of fat around that area, I actually don't always recommend an implant at that time. I recommend that they go see some of our colleagues in plastic surgery, have that fat removed, so that way they have easier access to their penis, and then they can pursue implant placement.
Thank you for that answer. Now, there's a question about the scratch technique as a treatment for Peyronie's disease. Does it also help ED?
Okay, so the scratch technique is a very specific maneuver that is done by surgeons during implant placement to break up Peyronie's disease scar tissue in anticipation of placing the implant that at same time. The scratch technique is never used with any other surgery or in isolation besides just doing an implant. And the reason being is that you have to place instruments inside the erectile body, which disrupts corporal tissue, which is that erectile spongy tissue. So if you try to do the scratch technique and not place an implant, you're just going to end up with a man with worse erectile dysfunction and impotence. So I love the scratch technique. I use it all the time in my men who have Peyronie's disease and are getting an implant. But it's like peanut butter and jelly. It's got to go with the implant placement.
Now, someone's taking oral medications, person's to Cialis, and that increases their libido more than they're comfortable with. Will lowering the dose also decrease their libido or put it more in control?
Yeah, that's a very interesting perspective. So, technically, Cialis should not do anything to libido if we define libido as the psychologic drive to have more sex. Um, but it can in a roundabout way, because if you are improving blood flow to your penis, then, well, you may be more interested in sex because all of a sudden, it's working. If let's say you're stuck in a wheelchair, you're not going to be interested in going, on a long hike. But if all of a sudden you can walk again, all it seems like a halfway decent idea. So you could try to lower the dose of the Cialis, but I don't think that's going to get at the heart of the issue. What I think is better in those scenarios is treating your ED. Because listen, if you need Cialis, then you've got erectile dysfunction. Just remember, whenever you were 15 or 25, all it took was a warm breeze to go by and you'd get an erection, and that wasn't pathologic or a problem. And if your libido or your drive to have sex is more than you need it to be, well, that's something that's worth discussing with a counselor or a sex therapist. And we work with some really good ones. And maybe it's something that you need to do with your partner, because there can be a mismatch in sex drive sometimes, and that deserves to be discussed.
Now we've got two more questions. First is, um, if, well, would a circumcision improve penis sensitivity and potentially help with erectile function?
No, absolutely not. So there are a lot of publications that would say that circumcision does not have any negative effect on sexual sensitivity and function. I have had many patients tell me otherwise. So I actually counsel men that it is very likely to affect sensitivity, and not always in a positive way. The only time that I think circumcision is really indicated, like it should happen, is in men who have what's called phimosis, which is contraction of that foreskin, where they can no longer see or, poke out the head of their penis. And if men have a lot of irritation that's associated with that, a lot of inflammation called balanitis, which can absolutely happen with a present foreskin and phimosis, well, then yes, fixing the phimosis through a circumcision can allow that tissue of the head of the penis to heal, which could improve sensitivity. But if you don't have phimosis and you don't have inflammation of the head of your penis, you don't have anything along those lines, then no, circumcision isolation is not going to improve penile sensitivity.
Thank you. And then the last question, if shockwave does not work, is the penile implant still an option?
Can you repeat that one for me?
So if shockwave therapy doesn't work for a patient, are they still able to get the implant?
Absolutely. And I have guys do that all the time. So I have a lot of men that come to see me. They usually the situation is that the pills don't work anymore, but they really, really want to try shockwave therapy, which is totally fine. It's one of the safest options we have for the treatment of ED. So they, will try shockwave. And if that doesn't work for them, then they'll, promptly move on to the implant afterwards. Very common.
I'd sort of lied there in the last question. What is the best way to get a hold of you if somebody wants to contact you after this webinar?
Yeah. So what I would recommend, guys, is actually calling our office. And I am going to go ahead and put this on the screen so you guys can see this. Okay. I'm going to try to make this a bigger part of the screen. Give me one moment. So I'm sure you can see that there. 877-362-2778. Again, 877-362-2778. And Mike, if you could do me a favor and just type that in the chat for our attendees so they can have that freely available, that'd be great. That is the best way to call and make an appointment with myself. I would recommend that you guys request an appointment with me specifically or with Kristen. I think that her schedule is more available than mine. And honestly, she does everything I do the exact same way. And if you're someone that's interested in seeking out an implant, she can counsel you for that. And honestly, she can probably get you on my schedule to get fixed sooner than even I can at this point. And so I recommend that you call us. If you want to learn more about erectile dysfunction and more about the implant, I do recommend visiting our website here. And Mike, if you could type this in as well, www.indymenshealth.com. Again, INDYMENSHEALTH.com. We've got we have a lot of really good pages and resources here. We've got a page called erectile dysfunction, which you guys can see here, where we walk through that mechanism of ED. I've got videos embedded, YouTube videos that explain the mechanism of erectile dysfunction. I think this is great. There's also a really beneficial series called the Hard series down here at the bottom of the page. This is like a documentary that walks through the journey of several men that have experienced erectile dysfunction. I tell you guys, if you want something to watch this evening, I mean, go watch the Hard series. It is absolutely incredible. And it is right here embedded on our website under the services tab where you see erectile dysfunction. So services, erectile dysfunction, scroll to the bottom, you have my videos, and then you've got the Hard series. And I recommend watching each one. You can see that they're embedded here. You can click on each episode and watch it in turn. And then I also recommend checking out our penile implants page. If you click that, it's going to walk you through the devices so that way you can understand them. I've got videos that are me walking you through the entire surgical experience, so there are no surprises there. And then also at the very bottom of the services is stress incontinence, which is walking through here with videos, talking about both the male sling that you can see here and the artificial urinary sphincter. So we have a lot of resources for you guys. And I think this is a great thing to kind of educate yourself on, especially as you're waiting for an appointment, either with myself or with Kristen.
We'll also send out an email tomorrow that has a link to the registration or the webinar recording video and this contact information.
Wonderful.
So it looks like there are no further questions. Dr. Tatem, I want to thank you very much for taking time out of your evening. And I want to thank everyone who joined us tonight for this webinar. Do you have any final thoughts you'd like to share with those who are still with us?
Yeah, I mean, I would just want to encourage you guys, don't live in fear. Don't put yourself in a situation where 6 months from now you're staring at the ceiling, wondering, what if you had pulled the trigger and sought a solution for this. Because the number one thing I hear from all of my men, whether they've received a penile implant, a sling, an AUS, is, gosh, doc, I wish I had done this, 3, 4, 5 years ago. I wish someone had told me about this. And this is an opportunity to get back really the quality and the joy in life. And that's what I want for all of my patients. I don't just want my patients to live a long life. I want them to live a full life. And having control of your bladder, having control of your sex life, that is one of the most empowering and reassuring things that a man can ever achieve. And so I want to help you get there. So again, I would love to see any of you as patients, and I very much appreciate you taking the time out of your evening to listen to our presentation tonight.
Thank you again, Dr. Tatem. This concludes tonight's Men's Health webinar. Have a wonderful
Thanks,
evening.
Mike. Thanks, everybody.